Now, Andy has been one of the main workers in this area over the last few years, and I'm very happy to invite him to talk on, at last, an easy test for diagnosing preeclampsia. Thanks, Andy. Oh, just before you go on, anyone who wants to put questions into the question and answer bit on flag in the webinar, please do, and we'll put these questions to Andy at the end. Thank you.
Great. Thanks very much. Thank you very much, Jimmy. And I just want to reflect what Lucy was saying. You know, Lucy was a phenomenal student, has now become a master. And I'm sure there's only a matter of time before Alex becomes the master. But just to kind of say to everyone, you know, nurturing others and building a legacy and a team is probably a much better way to influence the world than you'll ever do yourself. So I just want to kind of acknowledge that. It's actually a great pleasure to talk about this topic of this new angiogenic marker test that we now have available to us. And I wanted to take the next half an hour or so really to go through some principles about preeclampsia, its pathophysiology, and how it influences our management and how we can make a difference. I just want to acknowledge that there are a lot of biomarkers out there. There are a lot of companies that we need to promote them and commercialize. APEC actually engages with all the companies. I have no personal financial interest in any of the work we do, but they are a very important part of the success of getting tests. And we've been working very hard to make sure that they're going to be accessible to the whole world, not just to high resource settings. I guess everyone on this call has got an interest in preeclampsia, and I don't really need to spend time reiterating the impact preeclampsia has. I think one of the things about preeclampsia is we haven't yet cracked that nut of how to prevent it or cure it. The only way really to get rid of it, as it were, is to deliver the mother, and that has implications for the baby. And there are many, many babies that die and will continue to die. But there are some principles about preeclampsia I just wanted to go through. Firstly, we know there is huge inequalities around the world, and this is in the background of the fact that we don't have a cure. So what it tells us, of course, is that if it is managed well, the outcomes can be incredibly good. And this is a paradox because we sometimes forget how bad the outcomes can be, even though we haven't cured it. And so we have to look to around the world to see what's really going on with this disease. And even across high income settings, there are big variations in outcome. And this is largely attributed to access to care. So those countries that have universal healthcare provision, people get their blood pressure measurements and they get seen in a timely manner. The outcomes tend to be excellent in terms of very low levels of mortality. And even some high income settings with spend a lot of money on this, the poorer members of society who don't access care still have relatively high mortality rates. And I think this is important. I also wanted to share this slide. It's about to be published in BJOG, and it sort of reiterates the fact that most of the problems in the world, particularly in maternity, and if this particular slide looks at maternal mortality, you can see that the vast majority of deaths in maternal mortality are in the sub-Saharan Africa area. And this is, again, in the background of only less than 20% of the world's population being there, even though over 70% of maternal deaths. This is further confounded by the fact that the average age in Africa is a lot lower than the rest of the world. It's only 19. So the problem's only going to get worse. In the next 10, 20 years, the reproductive population is going to grow greater than anywhere else. And if we don't do something about this problem is that these inequalities are essentially going to get worse. The research we do is often in Europe or North America. You can see they represent a tiny part of the world's problems, for example, in preeclampsia. And, you know, Marcus, myself and Lucy wrote this editorial a little while ago when we had a huge success back in 2016 in the UK, when only 1 in a million women died from preeclampsia in the background of not actually having a cure. And this reflects the fact that if recognized and managed well, you can bring mortality way down. I wanted to share this data with you. This is one of the places we've been working in Sierra Leone, in Freetown, the main city there. these are two hospitals we work at, remarkable people doing remarkable work in both sites. They are both funded by the government. They both access government staff. They have the same populations that feed them. However, the mortality in one hospital is literally 25 times greater for the mother and 10 times greater for the baby. And so it's a lesson that even in the context of the same funding, the same staff, things can be a lot better through better organization, and it doesn't necessarily have to cost a lot of money. And I think we've learned a lot that simple things, simple cost-effective things can make a big difference. So it's about education and action as much as it is about resource. I think we have to think slightly differently about preeclampsia. Preeclampsia we've known about for 100 years or so, and it's come about to be characterized mainly by the blood pressure and by protein. But we know it's much more complicated than that. It's a body-wide problem. So essentially, it's a syndrome. And the definitions around blood pressure and protein are now a little bit outdated. And we can't be precise. And we do, unfortunately, get it wrong. So we can say someone has preeclampsia when they don't. And importantly, we think they're okay when they actually have preeclampsia. Just to illustrate this, I just want to show a couple of anecdotes. These are literally individual patients. So this is a woman who has her blood pressure done over a 24-hour period. You can see the blood pressure goes all over the place. It goes up and down, further confounded by the fact the way we measure it is not that precise. So in preeclampsia particularly, these blood pressure devices do underestimate the blood pressure. And equally, the other hallmark sign of preeclampsia, for example, proteinuria, if you dipstick one woman's proteinuria over a 24-hour period, you may get 2 pluses or a trace, depending on what she's been drinking, dilutional effects, and so you may be falsely reassured or you may over-egg it. As it happens in this case, this woman did have significant proteinuria, but on 3 occasions she only had a trace, which may have been falsely reassuring. And I think we all know as clinicians those questions about how do we manage this condition. It's quite difficult to predict in that woman who turns up with high blood pressure. Is she someone who's going to have a devastating, life-threatening problem in the near future, or is she going to be absolutely fine and have no problems at all? And we genuinely can't tell by the way she presents it a lot of the time. And equally, is her baby going to be fine? Is she going to have a stillbirth? And we do a lot of tests on these women to be reassured, and they're not all perfect. Should she be an inpatient? Should be an outpatient? Should she move somewhere where people are familiar and have sophisticated care in case she gets very sick? And perhaps quite importantly, how do you cure her? And that means when should she be delivered? This slide Chris Redman gave me, he sadly died last year, but a great guru in preeclampsia, but I love to show it and recognize him because he made this very astute observation that preeclampsia starts very early on in pregnancy. We just don't know about it, likely to be related to placentation, the placenta implanting. At some point, you develop the signs of it, and classically high blood pressure and protein. You may or may not get symptoms. They're not a good sign. But what's pretty sure is that you can put your mortgage on the fact that you will have a life-threatening crisis in a relatively short time, maximum 2 weeks, and often only a few days if it occurs preterm. So the funny thing is, we do have knowledge that preeclampsia is there now with these blood tests long before it is. And the challenge has been, how do we actually take that into clinical practice to help the people we look after? The classic textbook progression of preeclampsia starts from normal pregnancy. You develop high blood pressure. At some point, you develop preeclampsia. It gets severe. You then get symptoms. You have a crisis that affects the mother or baby and is life-threatening. Unfortunately, life isn't quite like that. We know that early onset preeclampsia can be worse for the baby. And unfortunately, classically now, this classical picture is not that common. It can develop very rapidly and without warning. You may even have an eclamptic fit, without prior knowledge of preeclampsia, or you may even die from preeclampsia without having an eclamptic fit. So it is not that reliable progression that is in the textbooks, and there may be features that are misleading. On the background of this, we do have risk factors for preeclampsia, but risk factors you cannot rely upon to target the right population accurately. The typical one here is obesity. We know you're 3 times more likely to have preeclampsia if you are obese. but most obese women don't get preeclampsia. And most women who have preeclampsia aren't obese. So that knowledge is only a vague indication of who to worry about. And this data from New Zealand, from Robin North, shows that actually more than a third, and the commonest presentation of preeclampsia is in women who have none of those risk factors. So the biggest group, 37%, have no indication of prior obesity, family history, or hypertension, which are the classical risk factors. And a very simple statistical quirk, which is nothing we can do about. If you have a condition that has low prevalence, and for preeclampsia that is typical, maybe in 2 or 3% of people, might be higher in some countries, but nevertheless, even if you have a good test with high sensitivity and high specificity, you end up having a lot of false positive tests. So your test is abnormal. You quite often don't have preeclampsia. So you have to have a really good test to get it right. Now, Robin North, back in 2011, put out this diagram, which I think was very interesting. These were all the substances that were different in women who were destined or who had preeclampsia. And everyone has been sort of chasing this holy grail of what is that substance that tells us if you have preeclampsia. At last, actually, we have sort of found it, and that is the angiogenic markers. We know that when PlGF is very low, and S-FLIT goes up, and they do kind of interact with each other, so they are biologically related. This is indicative of risk. Way back in 2000, actually one of Lucy Chappell's PhD subjects, we did know PlGF was low. And we know it's low from early on in people destined to get preeclampsia. Once you have preeclampsia, it is very low. And the reciprocal is the same for soluble FLIT. So in other words, you get very high soluble FLIT in people who have the disease. And there is a wealth of literature out there now. Susie Duckworth published this from our group back in 2016, which showed, when we looked at the 58 substances that were looking promising, that even if you took the top 8 of them, PlGF alone was almost as good as any combination that you could put together. And this was really exciting because it did mean you only need to do one blood test to get virtually all the benefit of a predictive marker. And again, there are many products out there, but what this ROC curve tells us is there's a very reliable point above which the test tells you you're very unlikely to have a problem. And there's another reliable point, which is low, below which nearly all the problems happen. So in other words, it is a very good rule out and rule in test. And if you compare it to what we used to do, which is take the blood pressure, measure the liver function, uric acids, it actually is a lot better. So this curve is telling us that the ability to predict whether you're going to need delivery in 2 weeks in someone who may or may not have preeclampsia, it is much more reliable than all those tests we used to do. And if you add in all those tests, they don't actually make the test any better. So the blood test alone tells us pretty reliably who's going to get preeclampsia. And if you look at this in clinical practice, this is one of our early studies. If you have an abnormal level, on average, you're going to need delivery pretty soon. So only about 8 days after you have the test. And this is a group of women who did not have preeclampsia. Conversely, if the test was normal, you would go some months. Essentially, it's saying that you're very unlikely to have a problem in the near future and probably the distant future. So this was very reassuring for us. And the final thing to say about that original data is it's not just you're picking out a very small group who are normal or a small group who are abnormal. In the average woman who turns up to a hospital in the UK, about a quarter of them were marked as being abnormal, and these all needed delivery pretty early, and about 40% were completely normal, and these all needed delivery months later. So in other words, it was a very useful test in clinical practice. And one of the early findings, which I think was incredibly exciting and important, was that if you look back at all the data, there were 7 babies that died in our first data set of a few hundred women. Every single one had an abnormal PlGF. In other words, not a single case was missed, even though in clinical practice, these cases weren't necessarily picked up in standard antenatal care. A very important principle is that there are lots of tests out there, and when we've compared them all, they are all good. So it's very difficult to say one is better than the other. They come from a number of different companies. This data from Alice Hurrell from the Parrot-2 study was probably the largest comparison of two tests, the ratio and the PlGF, in this case, the Quidel and the Roche test. And it was very reassuring to see that they're both equally good at predicting, are you going to need delivery from preeclampsia? Now, the next question is, what do you do? How are we going to use these tests in the future? We've done some studies looking at hypertension, and I just want to share with you some of the angiogenic marker tests from the CRADLE program. I think one of the CRADLE studies was we looked at 500,000 deliveries across a number of countries. And in that study, we demonstrated that preeclampsia represents about 22% of the deaths occurring. It's not the commonest cause, but it's perhaps the easiest one to treat because you can identify blood pressure and then do something about it. One of the trials we did in the UK was we delivered people a bit earlier from 34 weeks routinely to see if we could improve outcomes while checking that the baby was okay. And actually, it was beneficial to the mother, obviously, because that's how you make it better. But what was really important was there was no obvious clinical harm to the baby by doing that early delivery. And women were more likely to actually achieve a vaginal delivery, perhaps because the babies were stronger and healthier if they were delivered a little bit earlier. And this reassured our neonatologists that we were okay, although they still were taking babies to the neonatal care just to be checked, we believe. So we did the same study, Alice Beard-Morgray led on this in Zambia and India. And of course, this is where it really matters because there are many more stillbirths. And of course, removing the baby from the hostile environment actually is a good thing because the baby will grow on the outside. It doesn't have the sick placenta feeding it. You remove the risk of stillbirth, abruptions, and so on. But it may be immature. And what was really exciting about that CRADLE-4 study was, yes, we were able to prevent nearly all the antenatal deaths, and that actually represented 75% of all baby deaths just by routinely delivering 34. And there didn't seem to be a downside. However, it is still quite serious delivering a baby at 34 weeks in a low-income setting. And we do want to make sure we've got the diagnosis right. And this is probably where the angiogenic markers come in. In Sierra Leone, we scaled up the blood pressure device to hold the country. And I just wanted to show the slide to demonstrate just this really where it matters. There are so many deaths in each district. It's very hard to kind of replicate that in a high income setting. And this is where the benefit's going to be. So we're going to look at angiogenic markers. Now, we know the high S-FLIT, the low PlGF is that test that tells us. And what we've worked out is that the best place to use these tests is not early on in pregnancy, which you can do to target aspirin, not when you have preeclampsia, but in those you're not sure about. So the women who are walking with hypertension or who have other signs and symptoms. Kate Duhigg led on the first trial where we actually looked at the value of the test in clinical practice in the UK. We wanted to know how was the test performing, but more importantly, will it actually change practice that benefits the mother? And in a step wedge trial, yes, we diagnosed preeclampsia earlier, and it did benefit the mother. And based on this, the NHS decided to fund this and roll it out throughout the NHS. Here is the data showing preeclampsia is diagnosed earlier, and that there is about a 70% reduction in adverse outcomes, although adverse outcomes in this setting does not mean maternal deaths. There were other studies that were slightly different in Parrot Island, where they actually recruited a lot of people with just small babies rather than hypertensive. The benefit wasn't so clear. It wasn't significant, although there was like almost a halving, actually more than a halving of the babies dying. So it's probably underpowered, but looking good. And what we've learned from this is you probably should target this test to people who have hypertension or likely preeclampsia rather than IUGR, which of course can be a component of preeclampsia. Now, there are a number of tests out there that are recommended by NICE. And actually, there's now a different test recommended by the FDA in the United States by Thermo Fisher. And their more recent studies in 2022 are very similar to the early studies from Pelican and others in the UK. Essentially, you do diagnose preeclampsia earlier. It's much better test than all the old tests we used to use. And you know, very consistent message. And in fact, some societies like the ISSHP have now included angiogenic imbalance in the diagnosis of preeclampsia. The Parrot trial, the Inspire trial from Oxford, led from Oxford, using the ratio, have shown the same. Both these tests have been incorporated into NICE guidance and saying, basically, if you have abnormal, treat them more seriously as if you have preeclampsia. If the test is normal, you can be more reassured that you don't have to get worried. Now, there are lots of tests out there. These are the big ones in the UK, for example, and we know that they are relatively expensive. You have to pay £50, sometimes £100 when you start including the prepping agents. They have to be sent off to the lab. You have to spin the blood to get plasma and serum, and you may get a result back in a day or two. So there is expense, there is time, and a lot of the benefit of a quick answer is lost. One of them, the triage test from Quidel, actually is a bit more point of care, but it's not really point of care because you still have to spin the blood. You can't do it on whole blood, and it's still relatively expensive. So there is an alternative, and this is very exciting. So some of the companies who make the big analyzers are also developing other analyzers. The middle one there, the RONIA test, and the one on the right, the LEPSI test, are both whole blood tests, and they can be done on the bedside. Both companies that make that, Revity and LEPSI, are committed to marketing these at a lower cost, and you know, potentially at a very effective cost for using even in low-income settings. So there's no laboratory requirement. You have incredibly fast turnaround times, you know, possibly finger prick, even minutes. The women are kind of there getting the test done, are engaged with it, and certainly is potentially a runner in a low and middle income setting. So I'm going to share with you some of the results from our various programs of work, and they are very exciting. So this has been published recently, which is basically looking at these new point of care tests to rule in and rule out preeclampsia. And what I can tell you is they're just as good as the big expensive analyzers. So when we've compared them and come up with the relative cuts, they are reliably telling us that you're not going to get preeclampsia in a couple of weeks. And if you do have an abnormal test, you've got a pretty high chance of having a problem. I do want to show you this data, though, which is hot off the press, as it were, being considered for publication. I think this is from our teams. Katie Curtis led on this, and all the wonderful teams in Sierra Leone. You can see that in a data set, the first thing to say is in about 500 women, over 100 of them, so more than 20% of those women are actually, babies are actually dying. So we have a mortality rate, baby mortality rate of over 20% in women who come in with hypertension, which is a phenomenal lesson in itself. Of these 500, less than 500 women, 62 had a really serious event. And what I mean by that is they either died or they had an eclamptic fit. But if you look at these bar chart, let me take it through you. It's very important. On the right, there is no red in that bar chart. And what that means is if your PLGF is normal on this LEPSI device, there wasn't a single woman who died or had an eclamptic fit, and not a single baby that died. Conversely, if it was abnormal, very low, 50% of those babies died, and more than 20% were having a severe maternal event. So we have an incredibly good triage test in the context of one of the most challenging environments in the world to make a difference. We are now taking this test, and with our colleagues around the world, doing Papagaio, which is the parrot in Portuguese, because I'm working with Leandro Oliveira and his teams in Brazil, but also with our old teams in India, as well as phenomenal teams in Sierra Leone, Zambia, and South Africa, to actually look at these point of care tests in managing the problem, including early assessment, but also before 34 weeks and after 34 weeks in determining who you should deliver. So I think a very exciting program of work. The papers are being published now. They are definitely very good tests. Why do we need to know this? Because large parts of the world are very challenged in terms of triage. We know that getting a woman to the place where she can be looked after and potentially delivered in a timely manner is a huge lifesaver. And many women are far from any facility that can actually offer that care. And there has been great effort by many organizations in providing ambulance service and all sorts of other things. And the reality is that's not always sustainable. This is from our teams in some of the distant districts in Sierra Leone. A woman, if she is in trouble, has to get on motorbikes, get on boats. It is very challenging. And to have a simple test like the cradle device and then triage with something like a finger prick test or a simple blood test is going to make all the difference in terms of actually delivering her in a timely manner and saving lives. And again, this is the sort of action people have to go through to get a woman there. I'm going to finish now just by saying a phenomenal number of people have been involved in getting this work together, both in Zambia and Sierra Leone particularly. It's a huge effort by a diverse team with all sorts of skills. It's not just the clinicians, but the people who make things happen in the background, who help us with the governance, the travel. What a phenomenal team. I'm going to go back to what Lucy was saying. It's about legacy and building. These teams are going to carry on working for the next decades, long after I retired, I hope. And I think we are making a difference. The great thing about preeclampsia, if there is a great thing, is it's a terrible problem that has a relatively simple solution if we just grasp the nettle. So on World Pre-eclampsia Day, I think we have at last got a test we can actually use that could make a massive difference to these outcomes. And I'm really excited to kind of be in this space at this time. I'm going to be a little bit naughty and use this platform to advertise something. I always say to my team, if you have an opportunity, don't just moan about it, do something about it. A lot of our team are very interested in acute kidney injury, of which preeclampsia is a major cause. And I'm just going to ask you, if you can you go onto this QR code and spend time filling out this questionnaire? We're trying to work out how to prevent acute kidney injury, which also is involved in preeclampsia management. Hopefully I'll persuade Marcus to stick it in the chat so people can access it later as well. We've got time for some questions. And again, I wanted to thank everyone for spending the time coming to listen, and please do stay. We've got a very exciting next hour with a huge diverse group of people with immense experience from around the world. Jimmy, over to you if there's any questions.
Thank you very much, Andy. That's a very impressive overview of the subject and also the specific subject of PLGF. And what's interesting, if your last picture of your team, it's always important to remember the number of people behind the speaker who have done not all the work necessarily, but a lot of the work in actually getting the work together. And they're the ones that are going to move on and do work in the future, as Andy and Lucy have implied. Now, there are no questions at the moment in the Q&A part, please, and so please feel free to do that. There was one question in the chat, which you really sort of answered, but I'll sort of ask it anyway, and that is that it's asking whether you had any preference of the different tests for either PLGF in its own or the ratios, and you implied no, but of course this new point of care test might be a step forward. So, do you want to comment on that?
Yeah, no, I mean there are some more comments to make about that, Jimmy, and thank you, because I can actually expand a little bit. So basically, soluble FLIT, when PLGF becomes undetectable, it's just very low, and you know things are bad. Soluble FLIT will continue to rise. Therefore, there are some people who believe that you might continue to be able to triage the severity of the disease by looking at soluble FLIT, and the jury's out on that. We don't know whether you can track severity yet. However, the Gates Foundation and others are very interested in therapeutic measures here. So one of the things that's been looked at is suppressing soluble FLT with various therapeutic interventions, including messenger RNA technology. Now, if you're going to do that, you do need a measure of soluble FLT to titrate the drug. So although this is kind of, future stuff and we're a way off yet, there may be some merit and need to do soluble FLT measures for that purpose. However, today, if we just want to know, is the woman sick and do we need to deliver her, PlGF will tell you just as much as the soluble FLT. And we do know that the PlGF tests from the various companies is just as good as the ratio test from the various companies. So there are other reasons that we decide which test to use. One of them is, can we get a cheap whole blood test? And there are technical reasons why PlGF is much simpler on a point of care test than soluble FLT, although we are working with others to try and develop point of care tests for soluble FLT. And we have to watch this space. So things like, what does it cost? Can you do it quickly? Can you do it easily? So the aim is to keep it cheap, do a finger prick, get a result in minutes, have it by the bedside, and we're getting there. I think all the companies are working hard to try and provide that. And I think the cost is going to be the big thing for most of us around the world, I think, if we're going to make a difference to the people who need it most. But it is a nice move improvement in getting a really good test, better than all the other things we used to do, and it costs money, liver function, whatever. And I'm very excited about this. I think within months rather than years, I think this is going to become a reality.
Thank you. One of the first questions in the Q&A is from KV Malini, who's asking, at what period gestation do you recommend testing for PlGF?
Yeah, so I mean, the first thing to say is later on, it doesn't add much, because we know that if you have preeclampsia from 37 weeks, the default is to measure. And increasingly, we think that even delivering a bit early is a good idea. So you don't really need to do a test if you know you're going to deliver that woman. And actually, paradoxically, the test doesn't quite perform so well beyond 37 and maybe even beyond 35 weeks. So fortunately, the test works best before 35 weeks and maybe after 20 weeks when you want it the most. So those are the women where the baby may be able to survive. You have that delicate balance of when should you deliver it for maternal benefit, but not to harm the baby with immaturity. So the test seems to be most valuable in that point of care suspected preeclampsia cohort, those women who turn up, who've got high blood pressure, headaches, other symptoms, small baby, and you're just not sure if this is genuinely going to turn into a horrible outcome or not. That said, there are some people can use the first trimester test to actually say, yes, you're going to get preeclampsia much later. They can then target things like low-dose aspirin. So there is going to be work. And I think these point-of-care tests are also going to be good enough to be able to measure the low levels required for first trimester screening. And some of our teams are kind of working on that as well. So the quick answer is, that 24 to 35 week window is when it's most beneficial. Beyond and below that is still open for interpretation.
Thank you. The next question is from Ellie Watson, who is asking that they have particular problems in diabetic women and in deciding whether proteinuria is important because of obviously it could be the diabetes rather than preeclampsia. Is the PlGF or soluble FLT ratio reliable in that setting as well?
Yes, they are. And I can always rely on my previous PhD students to ask awkward questions. Ellie's one of those. So yes, I mean, the obstetric medicine and the physicians who are really delighted that we actually have a test that tells you in those challenging cases where you have underlying blood pressure trouble, you have proteinuria for other reasons. And you really struggle because they can be severely hypertensive or they can be churning out protein, and you genuinely don't know if that is a response to the preeclamptic process or that's a sign of an underlying medical condition. And we have plenty of anecdotes and more to say that the test is incredibly reliable in that group. So you can say, look, if the PlGF is normal, you know it's not the preeclampsia driving the pathology. It doesn't mean that woman's normal, because she still can have problems from the presenting condition and her diabetes, but it does mean that she's not going to have a crisis in the next few days from preeclampsia, and, you know, unlikely to have a abruption, unlikely to have a stillbirth, for preeclamptic reasons, and that really helps the management. So actually, more than paradoxically, that subgroup of hypertensive proteinuria women or other features of preeclampsia, it's particularly useful, has great clinical utility.
So just on that subject, Dr. Mandaba is suggesting that diabetes actually affects PLGF levels. So, the range is still valid, the same range as 12 as a cutoff point, for instance.
Yeah, I mean, there are lots of things that affect levels. We're looking at this. So, you know, everything from ethnicity and so on. The bottom line, and twins, you know, we just don't know. They do affect the levels, but at the end of the day, if they are very low and undetectable, that is usually significant. I think the literature is going to evolve and expand as we use these tests more, and we'll probably start getting subtle kind of changes in our pathways as we realize people are different in subgroups. But the bottom line is these subgroups will still have a benefit from these tests. In the same way as we sort of change our clinical algorithms for cervical length or whatever, depending on different subgroups, we'll probably change our management in the future. But the research is being done, and I think they're going to be reliable.
So on a similar subject is that Tracy Nelson comments that in their pregnancy assessment unit, they have fluctuating levels of PLGF when they measure women in a serial way, from mid-range and then to normal. And is that a common thing? You find that they can fluctuate from a sort of one band into another band?
Yes, so I mean, Alice Hurrell has done her entire PhD on this exact point, doing sequential readings and looking at the need for repeat testing. And that Lancet paper that came out in the last year categorically tells us there's no need to keep repeating it. There are small numbers who change categories. For the vast majority, it is either very normal, or it's completely undetectable, and you can characterize accurately. There is a subgroup that is intermediate. The conclusion from that study is repeating the test doesn't really change outcomes. So for most women, you do not have to repeat every week or whatever. There's a subgroup who will continue to be pregnant, say for a month or so, and may then represent with worrying features. And I suspect you have to have discretion. And if you do the test in that group, there will be added value. But we now know there's no need to routinely repeat, because the vast majority of people will be characterized accurately on the first test, and we know that repeating does not improve outcomes. Routinely, anyway. Yeah.
Again, and I think you've covered this to some extent before, and that is it a useful test for differentiating chronic hypertension and with superimposed preeclampsia? So
yes.
Would you follow someone with chronic hypertension, particularly to see whether they may develop preeclampsia?
Yes, I mean, there are differences in these women because, you know, aspirin benefit and stuff like this may be different in these subgroups, but at the end of the day, the test itself is very reliable in the same way as the diabetics and other kind of renal disease and so on can be discriminated. The chronic hypertensive who's, you know, becoming awkward because you don't know whether the growth restriction or the proteinuria or the symptoms are superimposed preeclampsia, this seems to be a great use of the test.
So another question is two questions really I put together, and that is that someone's commenting on the fact that even though it's in the guidelines, even though APEC have been pushing it very, very hard, it's not utilised in every hospital, and particularly in DGHs down the road from teaching hospitals, because of potentially of the cost and other barriers. So what barriers do you see that stops people using it? And is this new point of care test, will that actually open up the possibility that these hospitals who may have a slight less need of it on a regular basis to actually utilise it?
I mean, there's an out of sight, out of mind problem here. People don't know what they're missing. And I guess it comes down to local budgets and people having to pay for it. So even though it's recommended and there is money out there for it, it hasn't always happened. What's great is NHS England, as it was, has been able to kind of roll this out, and a large majority of hospitals have access to it. And through the work of, Mark is sitting next to me here, been badgering the Scottish government, and that looking better all the time. And so it is an uphill battle. In answer to your question, absolutely. Having laboratories having to take on these analyzers, the costs is not, although it's cost saving overall, the reality is someone has to fork out and buy these things and make it happen. If we end up having a point of care test that is a lot cheaper, there's no doubt that that's going to ease the way for using it. I think if it comes under the control of the clinicians, with the right governance blessings from their hospitals, I think people will kind of vote with their feet. Yes, this is a test I can have in my clinic, and I can benefit the women I look after immediately, rather than going through all the headaches of a laboratory-based test. So I'm sure costs and ease of access is going to help in the UK setting, as well as this sort of exciting work for the global health.
So just to finish off, Andy, one of the things, as you know, is that is one benefit to actually getting a diagnosis, or potential diagnosis, or risk categorization, is what to do next. And if we're going to improve the figures, then you've got to get the management right. How about the development of guidelines which are suited to the local environment? Is that something that APEC should be more involved with, and you're involved with, in helping people know what to do with the results when they get them?
Well, exactly. I mean, I think the NICE guidance has put the tests into that algorithm of when to upgrade or downgrade your actions, and you fall into the recommended action, so you can just read them. You're now green, therefore you're in this category. You're now red, you're therefore in this category. One of the work we're doing at the moment, and we're going around the world getting advice from our colleagues in South America and India and Africa about how will you use this test. And I think the bottom line is, if you have an undetectable level and you're red and you've come in with hypertension, we are telling people, treat this as preeclampsia. We're not saying deliver, we're saying treat this as preeclampsia. And conversely, if it's normal, we can say this is incredibly unlikely to be preeclampsia. You can act accordingly. So part of the trials is actually working through the actual pathways and the advice we're going to give people. If we can prove that it's safe to reliably say, treat this as preeclampsia and not treat this as preeclampsia, and we improve outcomes, then we can recommend those pathways. So it's an evolving area. I think, as you say, it has to be locally interpreted, and a lot of our work is actually looking at both community engagement and other engagement with our colleagues around the world to say, how would you use this in your environment? And make sure we're not causing a problem by reacting too quickly, but equally we want to prevent those stillbirths. So an exciting area. I think there's a lot of research that's going to come out in the next few years, and I think, in answer to your question, this will evolve, but there's no doubt in my mind it's a very good test. The question is, what's the best way to use it, and we will learn.
Okay, well, thank you very much, Andy. I hope everyone agrees with me that that's a very, very exciting sort of presentation with a lot of future involvement in it. And